Pulmonary embolism is the most frequently misdiagnosed cardiovascular disease in all of medicine. Roughly 1 in 4 emergency department patients who have PE don't get diagnosed until after their ED stay. And so my goal this year was in particular to evaluate how sex and racial bias can influence how physicians perceive the risk of pulmonary embolism and how that influences their decision to pursue testing for it. There's very little literature to date showing whether or not what physicians perceive the disease looking like actually corresponds with what patients actually present with when they come into the emergency department. Most of the literature on pulmonary embolism to date regarding misdiagnosis has looked at patient-level factors. What are the patient's symptoms? What are the patient's vital signs? What's the patient's medical history? But there's much in the diagnostic reasoning process beyond the patient. There's things that involve the physician's reasoning. We know that the workspace, the work environment, affects how physicians make their decisions. The initial process of diagnosis begins with building a differential, a set of conditions that the person might have. And that somewhat is influenced by objective measures. What are your vital signs? What's your medical history like? But a lot of it is subjective. How does the person look? Part of my project was trying to get at how physicians perceive the risk of pulmonary embolism and sort of what their threshold is for ordering testing on patients based on their gender. For this work, we partnered with Meadowlark. It's about 1,000 primary care practices and 7,000 clinicians. And we distributed the survey to this group to assess sort of their perception of PE and trying to get at their implicit bias regarding gender and race and how they work up this disease. So the survey that we developed, it first gives the participants a set of clinical vignettes for patients who have chest symptoms of some sort. And it asks them to rate what's their suspicion for several different diseases, PE being one of them. The second element of the survey is to get at what other components of someone's presentation makes you think that they might have pulmonary embolism or not. So for instance, we ask them a series of questions about how much does a patient, let's say, who has cancer change their decision-making? How much does someone who has chest pain change their decision-making? And if we're able to identify in this study what elements are driving physicians to perhaps inappropriately not pursue testing for pulmonary embolism, this will sort of be the foundational element for developing new educational materials and new training materials. It will help us inform people about how their perception of disease perhaps doesn't match reality and how they could change their diagnostic testing practices to improve their diagnostic accuracy. So there are 2 areas I'm really excited to work on moving forward. The first is this issue of cognitive load and how it affects diagnostic reasoning. The second issue is that we know that everyone has a working memory, and working memory is limited to about 5 or 6 things, and you can only hold them in your brain for about 20 seconds. The emergency department is an extremely challenging environment with interruptions frequently and many distractions, and we know that from other research that frequent interruptions and other things that impair your working memory lead to poor task execution, poor recall, but there's very little data to date on how the cognitive load and how the environmental distractions influence your diagnostic reasoning and your diagnostic accuracy. And so we're going to be measuring the cognitive load and the number of interruptions that physicians experience in the ER and assess downstream consequences of that on diagnostic accuracy. Pulmonary embolism is frequently misdiagnosed, but there are other diseases that are misdiagnosed. And I'm hoping that as we learn about how cognitive load affects the diagnostic process for pulmonary embolism, we can broaden that to study other diseases.